Hello everyone. Today I'll be talking about deep vein thrombosis and pulmonary embolism, starting with DVT. The pathogenesis of DVT mainly revolves around VIRCHOW'S triad, which I'm quite sure most of you know. It consists of venous stasis, endothelial injury, and a hypercoagulable state. Now, these are three factors that lead to thrombus formation. Risk factors for DVT can be divided into either inherited or acquired risk factors. Inherited, the most common would be factor V laden. In factor V laden, the factor V is not able to be broken down by protein C, so that's like a resistance to breaking down by protein C. Then the second is protein C, protein S deficiencies, and third is prothrombin gene mutation. Acquired risk factors include immobilization for prolonged periods of time, surgery like orthopedic surgery especially, malignancies, patients on oral contraceptives, pregnancy and hormone replacement therapy. This is mainly the estrogenic effect. Patients on central venous catheters, APLA syndrome, myeloproliferative disorders like polycythemia vera, essential thrombocythemia, and even nephrotic syndrome. So these are acquired risk factors for a hypercoagulable state which can lead to deep vein thrombosis. Clinical features of a patient presenting with DVT would be unilateral, mostly it's unilateral, rarely bilateral, limb swelling, pain and warmth. The calf diameter will be larger than the opposite side. Homan sign may be positive. Homan sign is basically a calf pain on passive dorsiflexion of the foot, but this is not a very reliable clinical feature. Now, the features can also be dependent on the location of DVT. It could be proximal, meaning the thrombus could either be in the popliteal vein, the femoral vein, or even higher up in the iliac veins. And distal is if the thrombus is located below the knee, so calf veins like peroneal and anterior tibial veins. And an interesting point here is that the risk for pulmonary embolism, that is what PE means here, the risk for PE is actually more from a proximal DVT than a distal DVT, but the most common type of DVT remains to be distal DVT rather than proximal. Now, for finding out the pre-test probability of deep vein thrombosis, we have something called a Wells score, and the Wells score actually gives 1 point to a list of criteria like a previous DVT, active malignancy, any recent immobilization of the lower limbs, the patient was recently bedridden for more than 3 days, localized tenderness along the distribution of a particular vein, presence of a swollen leg, calf swelling that's more than 3 centimeters compared to the opposite side, presence of pitting pedal edema, collateral superficial veins which are not varicose veins, and if an alternate diagnosis apart from DVT is more likely, you will have to subtract 2 points from the total. So how do you interpret the Wells score? As I mentioned, each of those criteria is given a score of 1, and once you add it up, a score of 0 means there is a low probability of DVT, or the pre-test probability of DVT is low. If it's 1 or 2, there is a moderate probability of DVT, and more than equal to 3, the patient has a high probability of DVT. So what is the subsequent, how will you evaluate a patient with suspected DVT? So the first thing is you check the pretest probability of DVT by calculating the Wells score. And if it is a low score like 0, then you will have to go with a D-dimer test, that is a test of choice. If the D-dimer test is negative, you essentially rule out DVT, and if it is positive, you have to confirm it further with a compression ultrasound of the lower extremity. If the compression ultrasound is positive, then DVT is confirmed and you can go on with treatment. But if it is negative, that essentially rules out DVT. So here the D-dimer test actually has a high sensitivity but a low specificity. This means that, just remember sensitivity and snout. So a negative D-dimer test can effectively rule out a DVT, but a positive D-dimer test is not specific for DVT because it can be elevated in many other conditions like malignancy, sepsis, pregnancy, trauma, even any recent surgery. But suppose our well score shows a moderate to high pretest probability of DVT, like a score 1 or 2 or more than 3, then you directly go with a compression ultrasound of the lower extremity. And if positive DVT is confirmed, then we can proceed with the treatment, which is basically anticoagulation. And if it's negative, it rules out DVT. So what is the treatment of DVT? The treatment depends on the location of the thrombus. If it's a proximal DVT, meaning in the femoral or the iliac vessels, you first determine, is it a very massive thrombus with a risk of limb ischemia? If it is, then you have to check if the patient is a candidate for thrombolysis. Thrombolysis is usually with thrombolytic agents like alteplase, streptokinase. If there is no contraindication to thrombolysis, we'll go with a catheter-directed thrombolysis followed by anticoagulation for at least 3 months. And we usually prefer a direct oral anticoagulant, that's DOAC. And this catheter-directed thrombolysis is when, using a catheter, we infuse agents like alteplase and streptokinase near the site of the thrombus. But suppose the patient has a contraindication to thrombolysis, we can go with surgical thrombectomy. And after that, you'll have to put an IVC filter because usually that patient cannot tolerate anticoagulation as well. Now, suppose a patient does not have a risk for limb ischemia, then directly check for any contraindication to anticoagulants. If not, go for anticoagulation for a minimum of 3 months duration. Again, the DOACs are preferred, that is the oral agents, direct oral anticoagulants. And if there is a contraindication to anticoagulation, then we will go for placement of an IVC filter. Coming to distal DVT, what is the treatment algorithm? For distal DVT, the first thing is to check if the patient is symptomatic or not. Because in patients, whether like the decision to start anticoagulation essentially depends on whether they're symptomatic or not. So if they are symptomatic with no contraindication to anticoagulation, then we go ahead and anticoagulate them for 3 months. And if there is a contraindication, we'll place an IVC filter. But suppose the patient is not symptomatic, then you'll have to have certain other criteria before you start anticoagulation. For example, if there is extension of clot into the proximal veins, that means there is a high risk for pulmonary embolism. Or if the D-dimers were very elevated, like more than 500 nanogram per ml, or if there were multiple distal veins that were involved, or if it's a risk factor that cannot be reversed, like a cancer or any long-standing inflammatory condition, or if there was a risk for prior DVT or pulmonary embolism, so the risk for recurrence is quite high. So in all of these conditions, the presence of these factors essentially increases the risk for either extension into the proximal veins or risk of recurrence. And if these criteria are there, we will go ahead and start anticoagulation. We will go to this particular algorithm. But suppose these factors are not there, what we do is we do serial proximal vein compression ultrasound every week for the next 2 to 4 weeks. So what we're seeing is we're checking if that DVT is extending proximally or not. If you find that in the subsequent examinations there is extension, then go ahead and follow the previous algorithm. Basically, we anticoagulate. But if there is no extension, then you can just manage them clinically. So clinical management is enough. So you don't need anticoagulation there. So coming to anticoagulation, we anticoagulate in 2 steps. There is an initial and then a continuation anticoagulation. The initial one is done for 10 days. The options that we have are low molecular weight heparin or fondaparinux or oral factor 10 inhibitors, and very rarely unfractionated heparin. So while thinking of initial therapy, there are a few considerations that we have to make. Like for example, for those who cannot take oral medications, that is when low molecular weight heparin is given, because that is given subcutaneously. And if low molecular weight heparin cannot be used, we'll go for fondaparin X. Then renal disease. In patients with renal failure, IV unfractionated heparin is preferred. The DOACs and low molecular weight heparin are actually contraindicated in patients with renal impairment with the creatinine with the creatinine clearance that is less than 30. Patients with liver disease. People with liver disease with coagulopathy, in those patients we prefer low molecular weight heparin. Then pregnancy, again we prefer heparin in pregnancy, not the DOACs, because they haven't been studied much in pregnancy. In case of malignancy, we prefer low molecular weight heparins again and not the DOACs, because DOACs are actually associated with malignancy associated bleeding risks, so we go for heparin. And hemodynamically unstable patients, like after thrombolysis, in those patients we prefer IV unfractionated heparin actually. Now a note here is that the direct oral anticoagulants like rivaroxaban and apixaban can actually be used as monotherapy without giving a pre-treatment with heparin. I'll talk about that more in just a minute. And also warfarin alone cannot be given as initial anticoagulation. You usually have to overlap warfarin with the heparin therapy in the initial few days. After that you can stop the heparin and continue with warfarin. Also, thrombocytopenia is not really a contraindication to anticoagulation. You just have to make sure that the platelet counts are more than 50,000 per ml. Now coming to long-term anticoagulation, we usually require a long-term anticoagulation up to 3 to 6 months, and the options here could be oral agents like factor 10A inhibitors like rivaroxaban, apixaban, direct thrombin inhibitors like dabigatran and warfarin, parenteral agents given subcutaneously like low molecular weight heparin and fondaparin X. So these are the two major options for us. And we have to think of something called transitioning. So transitioning is not required if a patient is to be continued on low molecular weight heparin or rivaroxaban or apixaban. You don't need any overlap therapy or any initial therapy for these agents. You start in initial 10 days and you continue with the same. But if you are continuing a patient on long-term warfarin or dabigatran, you do require a transitioning strategy. For example, if the long-term agent is warfarin, you will have to give an initial low molecular weight heparin overlapped with warfarin for about a week, and then you can follow it up with long-term warfarin. Suppose our long-term agent is going to be dabigatran. In this case, you have to give a pre-treatment with heparin first and then follow it up with dabigatran. But as I've mentioned, if your long-term agent is going to be LMWH or rivaroxaban or apixaban, they don't require any pre-treatment, so you can just give them directly and as a monotherapy without pre-treatment. Now, just a few points here. For the general population, oral agents are what we prefer over parenteral agents, and under oral agents we prefer the DOACs over warfarin, because as you all know, warfarin requires an INR, very periodic INR monitoring. But again, if the patient has a renal impairment, you can't use a DOACs. In that case, you'll just go for warfarin. Also, a note about the duration, like long-term therapy of at least 3 months uninterrupted is important, because this is the period of highest risk for recurrent thrombosis to occur. For some patients, the duration can extend to 6 to 12 months or even indefinitely, like if the underlying factor that caused the thrombosis is quite persistent. Like for example, some factors that cause a persistence is cancer, chronic inflammatory conditions like inflammatory bowel disease, obesity, nephrotic syndrome, continuous hormonal therapy. Now, these are things that are not transient. These are quite persistent or prolonged, so you do need prolonged anticoagulation in such patients. Now, coming to a few contraindications to anticoagulation. Absolute contraindications include active bleeding, recent surgery with very high risk of bleeding, any major trauma, or presence of intracerebral hemorrhage acutely. Also, while starting anticoagulation, you have to consider the age. Now, please be careful with elderly more than 65 years with a history of multiple falls, because these individuals are at a high risk of falls and the bleeding complications related with that. So you should be quite wise in starting anticoagulations in the elderly. Coming to thromboprophylaxis. Now, these are a few prophylactic measures that we take to prevent DVT, like patients who are bedbound in the hospital, admitted after a surgery. These are a few things that we could consider. So, pharmacologic thromboprophylaxis would be with either heparin or unfractionated heparin, fondaparinux, or the drugs. And mechanical methods of thromboprophylaxis include IPC, that is intermittent pneumatic compression. These are basically cuffs that are placed around the legs that inflate with air and squeeze the calves when they get inflated with air. And this squeezing of the calf is supposed to increase the blood flow in the leg veins. The second is graduated compression stockings, or GCS. These graduated stockings exert the highest pressure at the ankles, and then the level of compression slowly reduces up the garment. So what this does is, like, it's making sure that the blood flows up towards the heart, because that's how the gradient of pressure is. And this essentially helps reduce venous stasis. So you have pharmacologic and mechanical methods of prevention of DVT in the first place. Now, our next topic is going to be pulmonary embolism, and before I move into its details, I would like to mention a few terms. So, PE, that's pulmonary embolism, can either be acute or chronic. Acute is what presents immediately after occlusion of the pulmonary vessels, and as the name suggests, it will happen within minutes to hours. And chronic PE is when the thrombus keeps accumulating over time in the pulmonary vessels, and eventually, chronically, it will lead to pulmonary hypertension and its symptoms. Also, as I've already mentioned, most cases of PE arise from DVTs of the proximal limbs and less from DVTs of the distal vein. Now, consequences of pulmonary embolism. There are three major consequences that can occur. The first being a ventilation perfusion mismatch. So what happens in pulmonary embolism is you get wasted ventilation, because what happens is the blood, instead of being able to move further because of the thrombus, it gets redirected to other areas of the lung. And so since more blood goes to the other areas of the lung, those cannot efficiently oxygenate all that extra blood flow, and this can lead to hypoxia. Also, wasted ventilation leads to inadequate removal of carbon dioxide. So the patient tries to compensate that accumulation of carbon dioxide by hyperventilating. And when they hyperventilate, they remove excess carbon dioxide. This can lead to hypocapnia and respiratory alkalosis. So these are important ABG findings that you will see: hypoxia, hypocapnia, respiratory alkalosis. The second consequence that can happen is cardiovascular. Suppose there is a massive pulmonary embolus that completely blocks the pulmonary vessel. That increases the pulmonary vascular resistance. That mechanical obstruction, along with the fact that hypoxic vasoconstriction happens in the pulmonary vessels, leads to increased pulmonary resistance. That reduces the right ventricular cardiac output, that reduces the left ventricular stroke volume, and decreased systemic cardiac output from the heart. And this can essentially lead to hypotension as well. The third consequence is pulmonary infarction. So here, if small thrombi can block distal vessels that can reduce blood flow to those regions, it can lead to infarctions, ischemia and infarctions. These usually present with a pleuritic type of chest pain, and in severe cases it can also cause hemoptysis. But you should remember these pulmonary infarctions are pretty rare. Clinical features of pulmonary embolism is chest pain, which is a pleuritic chest pain which increases on inspiration, cough, dyspnea, hemoptysis. Hemoptysis is rare, but if it's present, that is quite significant. Tachycardia, tachypnea, and when you take an ABG, you find hypoxia, hypocapnia, respiratory alkalosis, and if it's a massive PE, it can lead to hypotension and shock. So for pulmonary embolism, we use again a modified Wells criteria. This score actually helps determine the pretest probability for pulmonary embolism. There was a Wells score that was not modified, that was used previously. That actually had 3 final scores, but the modified Wells score has only 2 final scores. That's like either less than 4 or greater than 4. So what is the criteria in modified Wells score? So 3 points goes to either clinical signs of DVT, or if an alternate diagnosis is less likely. So each of these gets 3. The next section would be of 1.5 points each, that is a history of previous DVT or pulmonary embolism, heart rate that's more than 100 per minute, or a history of surgery or prolonged immobilization. Now this prolonged immobilization doesn't actually just doesn't include your air travels. It has to be a significantly prolonged immobilization. So each of these gets 1.5 each. The next set is what receives 1 point each, that is the presence of hemoptysis or cancer. And when you add everything up, you can finally divide it into 2 sections. So one is a score less than equal to 4. That means there's a low pretest probability of PE and PE is less likely. A score more than 4 shows a high pretest probability, and that means that PE is quite likely. Now, the further evaluation for a patient with PE. Suppose you calculate the Wells score and you find that the patient has a low PTP for pulmonary embolism, then you'll go with D-dimer assay. If the D-dimer assay is negative, that rules out PE because D-dimer is quite sensitive. So SNOUT, a sensitive test, if negative, rules out the disease. But if D-dimer is positive, you have to confirm it with a CT pulmonary angiography. And I will be using the abbreviation CTPA further on in the video. So if CTPA is negative, that rules out PE, and if it's positive, that confirms PE and you can go for further treatment. But if the patient has a high pretest probability for PE, you directly go with CT pulmonary angiogram, CTPA. If that's negative, you rule out PE. If that's positive, that confirms PE. Also a side note here, in case of pregnancy or renal insufficiency, because of the risk for contrast-induced AKI in renal insufficiency, and because in pregnancy CT is contraindicated, in those cases we go for a VQ scan, or a perfusion scan is what we do in those cases. Now what I'll do is I'll go through an algorithm where we encounter a patient who we have a very high suspicion that the patient has PE and the patient is hemodynamically stable. So initial few management strategies could be by providing oxygen, either non-invasive, and if the patient really requires intubation and mechanical ventilation, that should also be considered. Then IV fluids if the patient is hypotension. Basically, after giving all these stabilizing measures, you find that the patient is now stabilized. In this stable patient, are there any contraindications to anticoagulation? If no, then you go to assess the Wells score for pretest probability. And as we've already seen, a low PTP is followed by D-dimer assay, and a high PTP, you actually have to start empiric anticoagulation before you do a CTPA. And then based on the results, if the patient is positive for pulmonary embolism based on whichever test you've used, you can start or you can continue anticoagulation if already started, and if negative for PE, stop anticoagulation. Right? So this is for a patient who has no contraindication to anticoagulation. If there is, then you first off assess the Wells score. If it's low PTP, again go for D-dimerase A. High PTP, go for CTPA. And based on the test results, if positive, instead of anticoagulation, we'll go for IVC filter. If negative, no further evaluation. So what I want to point out here, the major difference between the two arms of this algorithm is that in case of high PTP for pulmonary embolism, we actually start with empiric anticoagulation therapy before moving on to our CTPA test. Now that's quite important. And the initial anticoagulation that we use for all these cases is usually low molecular weight heparin or unfractionated heparin, along with either an overlap with warfarin or followed by a DOAC agent. So that basically is as I have explained in the DVT section. Also, long-term anticoagulation has to be done for a minimum of 3 months again, either warfarin or DOACs. And so basically those rules about anticoagulation are just as I've mentioned for DVT. Now, previously I talked about the algorithm for a hemodynamically stable patient. Now I will talk about the algorithm for an unstable patient who does not stabilize even after our resuscitative measures. In these patients, it's not safe to wait and transfer them for doing a CTPA. That is why we consider a perfusion scan, which is usually a portable perfusion lung scan, and if that's not available, then we go for a transthoracic echo. And we usually prefer a perfusion scan over a TTE because a perfusion scan has a higher sensitivity than the transthoracic echo. Now suppose it's a positive perfusion scan, or if you find features of right ventricular overload in echo, that basically means that the right ventricle is actually against a high pressure from the pulmonary artery, meaning the pulmonary vascular resistance is high, leading to the right ventricular overload. So in those cases, you have to assess if there is any contraindication to thrombolytic therapy. So this is where you have to really consider thrombolytic therapy because the patient is unstable. If there are no contraindications, we can administer the thrombolytic agent followed by anticoagulation. And if the patient has contraindication to thrombolysis, we will go for a catheter-directed or a surgical embolectomy. So what are the options for reperfusion therapy in a hemodynamically unstable patient? The first that I talked about was thrombolytic therapy for unstable patients. So the agents we use are tissue plasminogen activators like alteplase and streptokinase. These could be given systemically, or it could also be given in a catheter-directed fashion where the agent is directly infused into the pulmonary artery. The second option in patients who have contraindications to the thrombolytic therapy, we'll go for catheter-directed removal of the thrombus or the embolus, that is preferred, or we can go for surgery. So that is an option. So these are two options for reperfusion therapy. Now coming to monitoring, because we are starting a patient on anticoagulants, monitoring is very, very important. So you have to keep checking the levels of anticoagulant medications to make sure they are within range. So this is done by measuring APTT in case of heparin or PT-INR in case of warfarin. For heparin, our APTT target is 1.5 to 2.5 times the upper limit of normal. So this comes to about 60 to 100 seconds. For warfarin, our PT-INR target is 2 to 3, optimally around 2.5 is what we aim for. And in case of low molecular weight heparin or fondaparinux or factor 10 inhibitors or direct thrombin inhibitors, you do not require any monitoring per se. And in case you really do want to find out if the levels are appropriate, you could go for activated factor 10A level. So that's the first point. The second point is to watch for recurrence. So the chances of recurrence of DVT and acute pulmonary embolism is maximum in the first 2 weeks after the episode. So you have to be very vigilant to make sure that recurrence does not happen. Then you have to monitor for certain late complications like chronic thromboembolic pulmonary hypertension, and those patients will present with dyspnea. And the fourth is the IVC filter removal, because the IVC filter was placed in those people who had contraindications to anticoagulation. And if that contraindication resolves, the IVC filter has to be removed and the patient has to be transitioned to oral anticoagulants, because oral anticoagulants is what has been studied to have efficacy. Also, finally, we have to keep in mind complications of anticoagulants apart from bleeding, things like warfarin skin necrosis, heparin-induced thrombocytopenia, osteoporosis for patients on heparin, and various complications of the IVC filter as well, like filter migration. All of these also have to be kept in mind, and we should monitor for all of these very carefully. So that is with our video on DVT and pulmonary embolism. Thank you, and I hope you enjoyed it.